Focus on grafting. A burn is a trauma to skin cells caused by extremes in temperature, both high and low, friction, caustic chemicals, ionizing radiation, or electric current. 486,000 burns are treated in hospitals and burn centers each year in the United States of America. This number does not even include minor burns treated in walk-in clinics, private practices, or community centers. These numbers show us that burns are a significant public health issue. Mortality rates with burns increase with certain factors, including those of age greater than 60, patients with second degree or greater burns that cover a total body surface area of 40%, and smoke inhalation. I will get to more of the classifications of burns on the next slide. Here, I will introduce how patients present. As for superficial first-degree burns, patients present complaining of painful, red, blanching lesions that are typically painful for 2 to 3 days. They heal without scarring. They only involve the epidermal layer of skin. A good example is your typical sunburn. Note the blanching here. Patients with superficial partial thickness burns, second degree, complain of weeping red blisters and pain for about a week. They often heal without too much scarring, although altered pigmentation of the area may occur either temporarily or permanently. They involve the epidermis and dermis. Deep partial thickness burns are painful only when you apply pressure to the area, and patients complain of a cheesy white or red discoloration of the skin. These burns heal within 2 weeks with hypertrophic scarring. They involve both the epidermis and dermis, just like the superficial partial thickness burns, but they go deeper to include the part of the dermis containing hair follicles and glands. Patients with full thickness, third degree burns complain of decreased sensation and severe white or black skin discoloration that does not blanch. These lesions require surgical correction or skin grafting in order to avoid contracture in the wound healing process and poor functionality of the area after healing. Not listed in my bullet points here are fourth degree burns, which penetrate to bones, joints, and muscles. I have a photo of a patient here with a fourth degree electrical burn to the anterior trunk. You can see it goes down the abdominal musculature and the patient is in critical condition. Here I will explain the rule of nines piece by piece for repetition's sake. It was on the pack rat and Roush loves it. Head, 4.5% on each side for 9 total. Trunk, 18% on each side for 36 total. Genitals is 1% total. Upper extremity is 4.5% on each side for 9 total for each extremity, so that's 18% total for both upper extremities. Lower extremity is 9% on each side, 18 total for each extremity, so 36 total for both extremities. I would also like to mention that the Lund-Browder chart is a chart that combines TBSA and age to provide a more accurate estimation of burn severity. I don't think this is necessary information for your PANCE, but you may hear it mentioned in the ER burn centers when you are working. Diagnosis of a burn injury is mostly a clinical process. You really don't need labs or extensive monitoring for a first or second degree burn. In moderate to severe burn injuries, the body has a hypermetabolic response to the injury, causing a large release of inflammatory cytokines. This release causes the body to increase cardiac output in order to meet an increased oxygen demand by the burned, now inflamed tissues. Also, for up to 3 years after a severe burn injury, patients may have glucose intolerance, insulin resistance, or altered glucose metabolism. Assessment should always start with the ABCs: airway, breathing, and circulation. Then a cardiovascular assessment involving heart rate and oxygen levels should be obtained. Whether you have to ask a family member or the paramedic that brought the patient, you should try to elicit as best of a history as you can. A full body exam should be performed even if you only think that one body area is injured. To assess electrolyte and fluid status, get a CMP. Hypophosphatemia, elevated BUN, and elevated creatinine are common in burn patients. A metabolic alkalosis or acidosis could occur from burn injury, so an ABG may be required if this is suspected. Treatment. Treatment of minor burns involves cooling and cleaning the lesion with soap and tap water, providing pain relief via acetaminophen, NSAIDs, or opioids in more serious cases, and application of a clean dressing. Wound debridement becomes necessary when blistering or necrosis of skin occurs. If damage is very extensive, hospital admission may be required. In the hospital, patients may be administered antibiotics. No antibiotic prophylaxis is recommended for superficial burns. In partial or full thickness burns, clinicians may utilize a topical antibiotic ointment. Follow-up appointments should be scheduled for 1 day post-injury and weekly thereafter until the wound is fully healed. You should watch for infection or complications in healing, such as contracture or loss of functionality. If wound healing does not progress or complications arise, referral to a burn center or specialist, such as a plastic surgeon, may be indicated. Patients should be admitted to the ICU in the case of severe burns, those associated with inhalation injury requiring mechanical ventilation, hemodynamic instability requiring fluid monitoring, or organ failure. Further management involves pain control, coagulopathy and venous thromboembolism prophylaxis, nutritional support, and wound closure via skin grafting, which will be discussed on the next slide. Antibiotic therapy should only be used in cases of sepsis on those severely burned patients because they are so susceptible to infection with multi-drug resistant strains of bacteria. Burn prevention involves education, engineering, and enforcement, aka the 3 E's. Community and school-based education is available and not necessarily effective, but new platforms for education are emerging on video streaming sites like YouTube. With such high numbers of burn cases each year, it is evident that we need an improved public health approach to burn prevention. Skin grafting. Skin grafting is a surgical procedure that involves transplanting healthy patient donor skin onto burned skin. The surgeon selects a donor site based on the characteristics of the tissue that is injured. Full-thickness autografts contain both the epidermis and the dermis, while split-thickness skin grafts contain the epidermis and parts of the dermis. Full-thickness autografts require a large amount of donor tissue and are used on the perioral area, eyelids, head, neck, and scalp. Split-thickness skin grafts spare more tissue than full-thickness autografts. It is used more in the acute burn setting. Meshing is an example of an expansion technique whereby they take the skin and run it through a machine that makes it into a thin mesh, which allows the surgeon to cover a greater area of injured skin using a lesser area of donor skin. The main goal of skin grafting is to restore functionality to the injured area. This is accomplished by establishing a balance between keeping the patient still to allow the graft to incorporate into the injured area and keeping the patient mobile to maintain elasticity. Physical therapy and consistent, frequent follow-ups may be required.